those pictures end up being in the records because they're very important. Eventually, if there is a diagnosis that seems more likely, we can also order specific genetic tests. And then, when we did all this work, we tried to fit it all in a single diagnostic classification. This is the enormous list of genetic syndromes that are associated with CDH in some way or another. This means that CDH is part of all the other findings that you can find. So you see, it's very long. We're not going to talk about them all because it's very complicated. But these, I just want to point out that these are the frequent ones. So the ones that have been described more times, and so we know about them. But you know, there may be still more out there that are so rare, they're even rarer than the rare ones, that have been described maybe like 1 or 2 times, and so they end up not having a name and not being easily recognized. There are different mechanisms, and this talk will concentrate on CDH plus rather than isolated. There are different mechanisms when you look at genes that can account for what's going on. Some of them are chromosome changes, some of them are single genetic syndromes. I believe you talked yesterday a lot about the chromosome changes. So I just want to give you a quick overview. This is the standard karyotype. So this is the first layer of genetic analysis, even today. And you can perform this. So basically this karyotype is just looking at the chromosomes in a person. The genes are even smaller than that. Genes are really small stretches of DNA, and they end up being on top of the chromosomes. For every chromosome we have a pair. One of the, for instance, of the type 1 we got from our father, and the other one we got from our mother. And when we look at the karyotype, we basically look at the numbers. If there's an extra chromosome, if there's one missing, if the structure is fine, if some chromosomes are broken and fused to other chromosomes. So there's many kind of conditions that go on. This kind of test is performed on blood samples that's taken from the arm, so this is peripheral blood sample, or from amniocentesis or for chorionic villus sampling. And in the good statistics, in the good cohorts, it identifies rearrangements or changes in about 10% of CDH babies. Sometimes, if you have a negative finding at the karyotype, it doesn't necessarily mean that there is no change in the chromosomes. Sometimes the changes are so subtle that with this layer of detection, you just miss it. So nowadays, more advanced, more precise technologies are available, and some of those we apply in our laboratory as well. Most of them are used only in research. Some of them are also used in clinics. And this is a list of the most common recurring chromosomic changes in CDH. So you see there's a few extra chromosomes that can be found, and also a few more limited changes, deletions. So a little stretch of DNA is missing from the chromosome. These are very helpful from the point of view of research because they narrow down to very specific regions and to very specific genes within those regions that account for the phenotype. But today we will mostly talk about single gene syndromes, giving 2 examples. These are the most common genetic disorders, single gene disorders that are associated with CDH. There are different types. They can be inherited in a different way. And this kind of information is updated continuously. For instance, in this table that I pulled up from a paper of our collaborator, Kober, you see Donnai-Barrow syndrome is listed as a known gene. But actually, this is not true because Sibel Cantacci in our laboratory discovered the gene for that a couple of years ago. So this means that there is progress that's being done every year, and new information is coming up all the time. The first example that we're going to talk about is Cornelia de Lange syndrome, which is a funny story. It was reported independently by 2 different doctors, Dr. de Lange and Dr. Brachman. It's very rare. It's quite rare even among the rare syndromes. You see, it can be as frequent as 1 in every 10,000 or even 50,000, according to the statistics. There are different mutations in different genes. I listed 2 there. But actually there are 2 more genes that are going to be published very recently. Probably one is already published by now. Most of those cases are autosomal dominant. Now, when we say that something is autosomal dominant, it means that for every gene that we have in our body, we have 2 copies, right? One comes from our father, one comes from our mother. When something is dominant, it means that it's enough for just 1 copy of the gene to carry the mutation, for the disorder to be expressed and to be present. If you think a little bit about this, and we get a mutation from our parent, and 1 mutation is enough to give the disorder, then it means that the parent must also have it, right? Like this. This is not quite the case for the Longoni syndrome, because most of those mutations are new mutations. Are new mutations that arise right before the conception, so when the sperm or the egg are made, right? So even dominant mutations, sometimes they're not present in the family at all, if you look at the family history. So some genetic syndromes, some genetic conditions are not necessarily inherited from the family members, even if they are genetic in their mechanism. So CDH in Cornelia de Lange syndrome is quite frequent. It's not very, very frequent. It's quite frequent. There are at least 2,000 reported cases in the medical literature, which means there's probably others that were never reported. Whenever you have CDH in a patient that has Cornelia, this means that the phenotype is usually more severe than other patients with Cornelia. For instance, the abnormalities you find in the upper limbs are usually more severe, and also the other abnormalities are more severe in general. We talked a little bit about the genetic exam and why we measure like elements of the face and big pictures, and we analyze those, because the face is such an important thing in a person. It's the first thing we see. And so over the years, many of those syndromes were detailed and described very precisely in their facial appearance. So describing a face is very important to get to the diagnosis. So that's very hard, even for medical students, to understand this. This doesn't mean that every Cornelia de Lange patient has the same face, because of course, every patient is still born from their parents and will look like their parents. But there are subtle elements that can help the geneticist make the diagnosis. For instance, if you look at a Cornelia de Lange patient, you might notice the confluent eyebrows, which is called synophrys, or the long curly eyelashes, beside the descriptions you find, frequency of how common they are. And the low anterior posterior hairline, which means that there's a narrow forehead. The neat and well-defined arched eyebrows, and sometimes those are described in textbooks as though they're penciled in. And there's a long philtrum, the philtrum being the part between the nose and the upper lip, right? So anteverted nares, downturn angles of the mouth, then lips, so you see there's a lot of characteristics. I'm not going to read them all. This is basically what the CDH looks, with Cornelia de Lange looks like. You definitely can see the arched eyebrows, very characteristic, the form of the eye, the long philtrum, it's very apparent here, and also here, a little bit less. All the pictures that I'm showing you today are published pictures, just so that you know. So the privacy is not an issue here, because those were released for us to show. These are other features of Cornelia de Lange.